Okay, everybody, welcome to another episode of the JPN podcast. We're excited to have with us tonight Estee Rose, who is a certified genetic counselor at JScreen, a national nonprofit Jewish genetic disease screening program. Estee graduated from Yeshiva University Stern College for Women and then went on to complete her master's in genetic counseling from the Icahn School of Medicine at Mount Sinai. She has a special interest in communicating and community education and outreach and is proud to be a resource for individuals of her own community who are facing genetic health issues. And it's a special privilege for us as providers to have Essie with us to speak a little bit more about genetics, something that we don't really probably talk too much about or learn too much about. So thank you, Essie, for coming and joining with us tonight, and we're excited to hear from you.
Thank you for inviting me. Okay, I'm gonna share my screen. Let me know if it's working. Yeah, can you see? Amazing. Okay, so today I want to talk about, oh, hang on. My Wi-Fi is being weird. Sorry. Hang on. Okay, can you see me? Can you hear me? Can you give me a thumbs up if you can hear me?
Yes.
Yeah, we hear you.
Yeah, okay. Okay, so today I want to talk to you. Thank you. Okay, sorry, my Wi-Fi is being funny. Okay, so today I want to talk about incorporating genetics into your practice. I know that genetics is not very much emphasized in med school or in most people's training after med school. So I wanted to introduce you to the field of genetic counselors and genetic counseling and what we do, because I think we could be a really good support to you in pretty much any practice that you're going to be, or any specialty that you're going to be practicing. Genetic counselors are specialists who provide personalized care for their patients' genetic health. We are part of the healthcare team, have advanced training in medical genetics and counseling. So as Shimi said, I have a master's degree in genetic counseling, which is a combination of clinical genetics work and also counseling. We meet with people before or after genetic testing. Always prefer to speak with them before they do the test, just so that they know what kind of information they might get out of it. But certainly after results are ready, we speak to them as well. We specialize in many different areas of medicine. What's great about what we do is that we can do a lot of telehealth because most genetics is not doing any kind of physical evaluation. So we can do telehealth over the phone or by Zoom. And we also do other things besides for clinical work. So just a quick look into what a typical genetic counseling session looks like. I'll start here at 12 o'clock. We usually take a family history and a family medical person's personal history and also a family history to see if there is anything running in the family. Possibly we look for patterns to see if there's the same types of conditions over again in the same side of the family. We kind of just like want to get a full picture of everything that could be going on in the patient and their family members. When we think that there might be something going on, we discuss what we think might be going on and why we think that. And then we talk to them about different options for testing. So whether it's a blood test or it's taking fetal DNA through doing a CVS or an amniocentesis or doing a skin biopsy, whatever it is, we talk about the different types of testing that would be available to figure out what might be going on. And then when the results are ready, we review them with the patient and we talk about how it could impact them and their own health and how it could also impact other people in the family. Genetic counselors, in addition to kind of going through the whole case, we're advocating for our patients, we're empowering them with information, we're providing emotional support when there's a difficult result or a difficult family history, and we do, we're very into personalized medicine. So where you'll see genetic counselors, there are genetic counselors in the laboratory space. We speak to, laboratory genetic counselors will speak directly to patients. They'll also speak to providers who might not have genetic counselors in their office. So they use the lab genetic counselors to kind of be like a liaison between them and the patient so that they feel comfortable discussing results with their patients. We're also found in the lab in variant curation because genetics is a very fast moving world. We're always learning more and more about genetic variants and reclassifying them and trying to figure out what kind of a clinical impact these variants might have. So lab genetic counselors is kind of like the hot place to be right now in terms of genetic counseling, but I don't do that. I actually do clinical work. Many genetic counselors do clinical work in different fields, like reproductive medicine, pediatrics, and adult medicine. There are specialty clinics, so you might see like a cystic fibrosis clinic or a neuromuscular clinic, or a cardio clinic, and cancer is another very, very big or hot place in the genetics world right now. In addition to doing clinical work, we also teach a lot. We are very involved in policy development and advocacy for patients, and we're involved in laws and passing bills and trying to get insurance companies to cover genetic testing. So we're a very passionate people about what we do, and we are here to help you. So besides for just knowing the information, there's a lot of nuances that come along with genetic counseling. Very often there are very complex results that even I sometimes don't understand, and I need to speak directly with the lab director to figure out what's going on. Sometimes there are results that we didn't expect to happen. We might find things by accident, things that we're not looking for. And we need to navigate those types of results with our patients. When we do deal with a diagnosis or we tell people that they're positive for something, there's a lot of emotional support that comes with that. We also involve other people sometimes in the session as long as the patient consents. So whether it be their family members, whether it be their partner, very often I'll have rabbis like very, very often call me and they'll say, I have, a student of mine or a congregant of mine who's dealing with this issue and they're asking me halachic questions. Tell me the facts, tell me what I need to know so that I can be helpful in terms of making or giving some kind of halachic advice. And really what we're doing is we're taking very complex information and we're breaking it down to more digestible pieces of information so that people can understand it. So a genetic counseling session is usually not that short. A very basic one might take 10 to 15 minutes, but most of my sessions, could go up to an hour, especially ones that are positive. And then, of course, there's follow-up as well with the patients. Where to find genetic counselors. So like I said before, we meet with patients before and after genetic testing, preferably before, for informed consent purposes and so that people understand exactly what type of information they might learn. You can find genetic counselors in different genetics clinics. So many big hospitals, especially teaching hospitals, will have a genetics department with genetic counselors there. A lot of OBGYN and breast health practices now employ genetic counselors. So they have in-house counselors. A lot of cancer practices will also have genetic counselors. And as I mentioned earlier, genetic counseling works very well to do telehealth with genetics. So I work at JScreen, which I'll talk about a little bit later, but there are other telehealth genetic counseling services like at the lab, and there are a couple other private companies that offer genetic counseling by telehealth. If anybody ever needs a genetic counselor or they need to refer a patient to a genetic counselor, they can use the National Society of Genetic Counselors findageneticcounselor.com website, where you just have to go to the website and you can input a zip code and they'll hook you up with local genetic counselors. So a little bit about JScreen, where I am a genetic counselor. JScreen is a national nonprofit genetic testing and education program. We offer two different types of tests. This is just a screenshot of our website. We have a carrier screening test and a cancer test. So I'm going to talk to you about both of those and what we have to offer. There are other types of genetic tests out there that we just don't offer, but again, if a patient of yours might be a good fit for other types of genetics and JScreen might not be the place to do it, findageneticcounselor.com is a good way to find a genetic counselor who could do it. Or you can always contact me and I can help refer you out to other places. So today we're really just going to focus on the carrier screening and the cancer test, but there are many other times where a genetic counselor can be helpful to your patients. So our reproductive carrier screen is a panel of over 260 conditions, and the purpose of the screening is for reproductive reasons. So if an individual or a couple is planning on having a child and they want to see if they're a carrier for a recessive condition, they would order this reproductive carrier screening test. It's appropriate for anybody pretty much who's interested in having a child. It doesn't make a difference what their sex is, doesn't make a difference how old they are, as long as they're using it for reproductive purposes. This is the way to do it, is to order this test. JScreen is available in all 50 states because everything is done by telehealth. So We recommend that people do this test prior to any pregnancy. Very often people will tell me that they did Dori Sharim, or they did, which we'll talk about in a few minutes, but or they did the testing before they got married and now they're thinking about having their third or fourth child. It's really important to know that these tests do get updated over time. This is a picture from my dad actually gave me this picture. He used to work at Einstein, and Einstein had this program in the late 70s and early 80s where they would literally go around in this van right here to different communities. They would go around Manhattan and the Bronx and Queens, and they would even go as far as Baltimore and Boston, and they would test people to see if they're carriers for Tay-Sachs. At the time, Tay-Sachs was the only condition that we knew how to test people for to see if they were carriers. 1 in 30 Ashkenazis is a carrier for Tay-Sachs. There was actually an entire Tay-Sachs wing of a hospital up in the Bronx, and they knew that this needed to be stopped, and they figured out that babies who have Tay-Sachs disease are missing a certain enzyme called hexosaminidase A, and they noticed that the parents of these babies had half the amount of non-carriers of this enzyme. So they would go around in this truck and they would go to shuls and just anywhere where Jewish young people were, and they would test them for this enzyme activity to see if they had the normal amount or if they had half the amount, which would mean that they're carriers. And at the time, anytime they saw a carrier couple, they would advise them not to get married. Now, we probably all know here that that's no longer what we do, but in those days, that was all they had. And knowing that there is a carrier couple, that would mean that there's a 25% chance for each of their children to be affected with Tay-Sachs. So they would say, not a good idea to roll the dice, just don't get married. Well, a lot has changed since then. Now we're screening for way more than Tay-Sachs. Here's a little timeline. You can see how many diseases we've tested for over the years. As I mentioned, now we're up to 265 conditions. And these conditions are not only Ashkenazi, because we learned that there are also conditions that are common among Sephardic people, and there's also conditions that are common among people of other ethnicities, and even pan-ethnic, which means that they're common among people of all ancestries. And we also know that anybody could be a carrier for these conditions. So being Jewish puts somebody at a higher risk of being, but it doesn't mean that people who are Ashkenazi are exclusively carriers. Like anybody could be a carrier. It's just more common if you're Ashkenazi. So because people have mixed ancestry, or because people have maybe converted over the years, and or maybe people don't really know their ancestry and they think they know their ancestry, the new thought is not to test people only based on their ancestry. Like it's not just because you're Ashkenazi, we should test you for the Ashkenazi conditions. Now we just test everyone for everything, and we cast a wider net just so that we don't miss any carriers. Back in the day of genetics, it used to be very expensive to do genetic testing. They would test each gene one at a time. And it was a few $100s per gene. So testing was really, really hard to access. It was expensive. It involved going to the genetic counselor and getting your blood drawn and, taking off a day of work to do this. It was hard. But nowadays, everything is much more accessible. And now we use an array technology where we test for every single gene at the same time. So it's the same exact price if you're testing for one condition or 700 conditions. So between the cost and the convenience of doing it and knowing that people have mixed ancestry, we just say, just test everyone for everything, because you might as well, and you might as well get higher detection rates and miss fewer carriers if you're going to test everyone for everything. So no longer are the days where they would go around in the vans. Now you could just go online and order a spit kit to your home, and we test for many, many conditions. And in addition to that, we're not advising carrier couples to not get married. So I'll talk to you in a moment about other options that we give our carrier couples, but who should be doing the screening? Like I said, anybody who's considering a pregnancy. It doesn't make a difference if they're male, female, or using an egg donor or sperm donor, how they have their babies doesn't make a difference. Anybody planning on having a child, carrier screening can be done through us at JScreen, or they could go see a genetic counselor. And it's always best to do this testing before a pregnancy, because more options will be available to you if there is an issue before pregnancy. So I'll go through those options now, and you'll see why some of those options are just not doable if there's already a pregnancy underway. Many people ask me about Dori Sharim, or they've heard of Dori Sharim, maybe they've even used it themselves. So I just want to give a quick summary of the differences between what we do at JScreen and what Dori Sharim does. So for people who are unaware of Dore Sharim, it's good to know because your patients might ask you about it. Dore Sharim is an organization that started in the 80s in Brooklyn. It was started by a man who lost 4 children to Tay-Sachs. He and his wife lost a lot of, they lost a lot, besides for their children. It was just really, really hard to have to go through that so many times. And they said, we can't allow this to happen to other people. They were a Satmar family, so they were very Hasidic. And in that community, they understood that if the rabbis would come out and would say everybody has to do Tay-Sachs testing, there would be an uproar in the community because of the fear of a stigma. If you know that you're a carrier, people might think there's something wrong with you and you're not a good person to marry and you're not like it would kind of just be like a stigma on them if they saw that they were carriers. Now, we all know that being carriers for these conditions doesn't really mean anything about the person and how good of a husband or wife they would be. It doesn't mean that there are any health issues related to being a carrier. But in that community, that's just the norm, and people are scared, or they were scared in those days, of letting it be known that people were carriers for things. So this couple needed to think of a way to get the testing done, because that's the goal here, is to prevent babies from being born with Tay-Sachs. But they needed to do it in a socially acceptable way for that community. So they came up with this brilliant idea of Dore Sharim, where they would test people for Tay-Sachs, but they wouldn't give them their results. Instead, they would just give them an ID number. And then when a couple was, connected together, both of them would give their Dore Sharim ID number to the Dore Sharim hotline, and the Dore Sharim lady on the other side of the phone would look up both of the results and would say carrier couple or not carrier couple. And if they saw that it was a carrier couple, they would say not a match. We advise that you don't go out on a date. And if they saw that they were okay and that they were not a carrier couple, either both of them were negative or one was positive and the other one was negative, they would say okay to proceed. Dore Sharim is still around. They have added more diseases to their panel since then. So now it's not just Tay-Sachs. They're testing for about 30 different conditions. And people often ask me, what's the difference between JScreen and Dore Sharim? So I will say that we are similar in that we have similar goals of trying to prevent babies from being born with common genetic diseases, but we have different ways of doing it. So here are some differences between what we do and what Dore Sharim does. The first difference is the number of diseases on the panel. I mentioned before that we're testing for 265, and that number is going to continue to go up. And they are pretty set in their ways about testing for about 30 different conditions. They're not testing for more. There are philosophical reasons that they choose to do this that I'm not privy to. I am not part of their program, but they are pretty strict about that, and they're not going to be testing for more than that. The technology that they use is also different than the technology that we use at JScreen. JScreen is a medical grade test, so we're using CLIA approved clinical labs. They're not. They're using a different lab, and the technology that they use is called genotyping, where they test for a few different mutations in the gene, but they don't test the whole gene. They don't just pick random mutations. They pick what we call founder mutations, which are basically like hotspots on the gene that we know are more commonly seen to have mutations in people who are Ashkenazi. So they're not picking random spots. They're picking the ones that we think there might be something going on, but they're not looking at the whole gene. Looking at the whole gene is a different technology called sequencing, which is what we use at JScreen. It's pretty much standard of care now that when somebody's doing carrier screening, they should be doing sequencing because we don't want to miss out on mutations. We recommend, as I said earlier, prior to any pregnancy that somebody does JScreen or make sure that their testing is up to date, maybe even update their testing, because you're a carrier for something whether you know it or not. So it's always better to have the best test out there and know what you're carrying. At Dore Sharim, their protocol is only to do their matching before the dating process. And once a couple is married, they don't recommend updating testing. They also do not use insurance. At JScreen, we do bill the testing through insurance. And one of the biggest differences is that we share the results. So at JScreen, people get tested, they get their results through me or through one of the other genetic counselors. They have the option to also review the results with their partner. So we could do a joint genetic counseling session if they want. They know everything. Like, we lay all the cards out, they get their lab report. We have a long conversation. At Doris Charim, as you know, they do not give the results. People just get their ID number. And genetic counseling, like I said, is strongly recommended. So we are similar in the sense that we're trying to prevent carrier couples from having children with genetic diseases. But the way that we do this, or that we achieve this goal, is different. And if anyone has any questions, I'm happy to answer later on, but just two different ways to do it. So with people who come to JScreen, where we do talk about different options, we're not only telling people to break up like they used to in the 80s in the vans. Now we give people a whole slew of different options. I am very careful about writing in no specific order here, because I see that every couple is different. So sometimes I'll have a couple where they went on 3 dates and they find out that they're a carrier couple. Sometimes I'll have a couple who got engaged 3 weeks ago. Sometimes I'll have a couple who's already started their family and they're updating their testing. Sometimes we're talking about diseases that are very mild, and sometimes we're talking about diseases that are fatal in infancy. So every couple is coming at it from a totally different place. Some of my patients are Jewish, some are not Jewish, some are Orthodox, some are not Orthodox. So everybody's kind of like their own unique has their own unique scenario and situation. So we're very careful at JScreen to give all of the options and kind of talk them all out, talk of the pros and cons, and let the patients lead the way, to see what they're kind of thinking of, and then kind of following their flow and talking more about the things that they seem a little bit interested in. So when we do have a carrier couple, we will give the option of natural conception with the option for prenatal testing. So we can test fetuses during a pregnancy, during the first trimester with a CVS, and the second trimester with an amniocentesis. We talk about getting those results and then using that information to either continue a pregnancy or to sometimes terminate a pregnancy in certain cases. For couples who are not comfortable with that option, they might decide to use assisted reproductive technologies like an egg donor or a sperm donor. Some couples will decide to use IVF with PGT, or pre-implantation genetic testing, where we test the embryos for the disease in question before we even implant it. Obviously, you cannot do IVF or use an egg donor or sperm donor if you're already pregnant. So this is why I was saying before, it's always better to have results prior to a pregnancy so that you have these options. And in many cases, I will have couples who decide to move forward with things and go through IVF. And in many cases, they say, no, this is not for me, we're going to break up, which is another option. So some couples will decide to not date anymore. Some couples might not have kids anymore, or might not have biological children. They might adopt, or they may foster. So like I said before, every case is so unique. And that's why the genetic counseling piece, I think, is a really important part of the conversation. And that's our whole carrier screening test. If anyone has any questions, you can write them down or put them in the Q&A and we could discuss them later. But that's where JScreen started. We started out by doing this carrier screening. And throughout the first couple of years of JScreen, we've got many, many questions about hereditary cancer. So BRCA, for example, a lot of people have heard of the BRCA genes. They know that people who are Ashkenazi Jewish have a higher chance of having a mutation. And for many years, we weren't ready to offer testing for it because we felt that it wasn't like the same part. It's not the same thing as doing carrier screening. Yes, it's genetic testing, but they're apples and oranges. One of them is testing healthy carriers to see if their kids might have something. And testing for hereditary cancer is testing people to see if they themselves might have something. And it took us a while to convince ourselves that the community was ready for this type of information. We actually did a study that I was a PI on, where we asked the community, is this really what you want? And we saw a very, very high number of yeses. Like, we saw that the community was ready for this, which is why we launched our second test, which is our hereditary cancer test. So with this test, we're testing for 63 cancer susceptibility genes, covering over 40 different types of cancer. This test is appropriate for anybody over 21 years old who's interested in learning if they have a hereditary risk for cancer. So a little bit about cancer risks. So something you might see as physicians when taking a family history is sometimes you see patterns, right? So you might see a lot of people on the same side of the family with the same types of cancer over and over, or related cancers. So you might see, many women in the family who've had breast cancer or ovarian cancer. Sometimes you'll see people who've had a diagnosis at a pretty young age, like let's say in breast cancer, premenopausal breast cancer. Being Ashkenazi puts someone at a higher risk to have a mutation. So anytime you see any of these patterns, you kind of think of them as red flags. Like maybe there's something going on here, and it's not just sporadic cancer. Most breast cancers actually are sporadic. Only about 5 to 10% are hereditary. But when you see those clues, you start to wonder, like, maybe there is something hereditary going on. So we test, like I said, for over 60 different cancer genes, but I'm going to use the BRCA1 and the BRCA2 gene as examples, but there are many other that we're testing for. So these genes are cancer genes. The job of a cancer gene is to protect us from getting cancer, but if somebody has a mutation in these genes, it makes them not work so well. So we're losing some of that protection. So when somebody tests positive, when they have a mutation for any of these cancer genes, they have a genetic predisposition to getting cancer. It's not a guarantee that they're going to get cancer, but the risks are higher because those genes are not working properly. We test for colon cancer genes, we test for prostate, pancreatic, breast, ovarian, melanoma, everything pretty much on this panel. So I'm going to focus on the BRCA1 and 2 genes right now. Sometimes I notice I say BRCA, sometimes I say BRCA. It's the same thing. I don't know why I switch off. I just do. That's what my brain does, but it's the same thing. So for women who have a BRCA mutation, the risk for both breast cancer and ovarian cancer is significantly higher than the general population risk. Here you can see the general population risk for breast and ovarian cancer, and that number, both of those numbers are very, very increased for women who have a BRCA mutation. For men who have the mutation, there's also an increased risk for male breast cancer and prostate cancer. Here are the general population risks, and here you can see those with a mutation. And both men and women who have a mutation are at increased risk for pancreatic cancer as well. The BRCA genes are kind of like a really good example because the risks are so increased, especially for breast cancer and ovarian cancer. The risks are not always this high, for all of the genes that we're testing for, but for these ones, yeah, they're quite significant. So having a mutation doesn't guarantee that somebody will have a diagnosis of cancer. None of these numbers here are 100%, but the numbers are quite significant. So when somebody does test positive for a mutation, that's where we come in as the genetic counselors, and we talk through the results. So we explain to the patients what it means to have this mutation, who in the family needs to learn about it. I'll tell you about that in a moment, and what they can do with this information. So we are not testing for genes where there's nothing you can do about it, because that's not very helpful to people, to know something's coming and there's nothing they can do about it. We're very thoughtful and careful about which genes we're going to test for. We test for the actionable ones. So depending on which gene we're talking about, it's always going to be a different conversation. Let's use the BRCA genes as an example here, but maybe I'll throw in some other examples along the way. For some of the cancers, we do recommend more frequent cancer screening. So let's say a woman who's BRCA positive might go for mammograms starting at 25, or usually 35 versus starting at 40. She'll start going for an MRI at 25, a breast MRI, where normally women don't do breast MRIs. If we're dealing with a colon cancer gene, people might start doing colonoscopies at 40 instead of 45, and they might do them every 5 years instead of every 10 years. So again, depending on which cancer type we're talking about, it's always going to be a different recommendation, but the point is to do more enhanced screening. So whether it's starting earlier or doing it more frequently or doing it at all, as opposed to the general population, that will be specific for the patient. Sometimes we talk about lifestyle changes when we're dealing with a patient who already has a cancer diagnosis. Knowing these results could be helpful in terms of determining what treatment might be good for them. So there might be targeted medications, there might be targeted surgeries. So let's say we have a woman who has breast cancer on one side, and then she finds out that she has a BRCA mutation. She might decide to do a double mastectomy because there is a pretty significant risk for contralateral breast cancer of the other breast. So knowing the reason that she had cancer could be really helpful for her treatment. In some cases, we will recommend risk-reducing surgery. So we'll remove a part of the body that is susceptible to getting cancer before it even happens. So for BRCA carriers, we do recommend that all females do remove the ovaries by the time they're done having kids, or around 40, 45, whichever one comes first, because the risk is so high for ovarian cancer and the screening is not so good for it. So there's a lot that goes into these positive discussions and deciding, or the guidelines that are out there for each patient, and each cancer type is like a very, very big part of the conversation. For our younger patients, we also talk about reproductive options, the same exact options that we discuss with our Tay-Sachs carrier couples, we'll discuss with them as well. So if a couple is dealing with a parent who has a mutation and they want to make sure that their future kids don't have it, they also have the option of undergoing PGT. They can also use a donor. So that's definitely part of the conversation. It's not just breast cancer. So I know that we've been focusing on BRCA, but as I mentioned, there are other types of cancers that we're testing for. And when it comes to breast cancer, it's not just BRCA. There are other breast cancer related genes. Everybody knows the BRCA genes, but there are more, and we're seeing positives for them all the time. So if somebody says to you, yeah, I tested negative for BRCA a few years ago, I would push harder and say, well, now there's more testing available. It's not just BRCA. Maybe it's one of these other genes that might have caused the breast cancer in your family. So just like with the carrier screening, the cancer screening also gets better over time as we learn more and more genes are added to the testing panels. It is recommended that high-risk people who we haven't figured out yet what's going on might want to consider updating their testing. The way that most of the cancer genes are inherited is dominant. So if somebody has a mutation, each of their first degree relatives has a 50% chance of having that mutation as well. And if they have that mutation, those risks would apply to them as well. It doesn't make a difference if their first degree relative is male or females, it's 50-50. So anytime somebody has a mutation, each of their kids has a 50-50 chance of inheriting it. And the cancer risks will obviously differ depending on the sex of their children. I mentioned earlier that being Ashkenazi puts somebody at higher risk to have a BRCA mutation. The general population risk is about 1 in 500, but those who are Ashkenazi have about a 1 in 40 risk, which is pretty much the same stats as being a Tay-Sachs carrier. So it's a real thing when you have an Ashkenazi patient tell you that they have a family history of cancer. Like, sirens should be going off in your head. Like, is it possible that it's something BRCA related? Very often people will test positive at JScreen and they won't have a family history, and it will kind of look like an incidental finding, like, where did this come from? The reason is that a lot of families are not that informative, and we don't see those patterns that I mentioned earlier, but there could still be a mutation, either because they have a small family or they have limited information. People didn't necessarily talk about it. People back in the day didn't do breast MRIs, the way that we do them now. So there's just less information about people than, from the past than we have nowadays. You can have families that are predominantly male. So it's possible that had this family been a predominantly female family, we would have seen breast cancer and ovarian cancer. There just aren't any females, and that's why we're not seeing anything. And like I said earlier, not everybody who has a mutation has cancer. So you could have people in the family who have been lucky and never had a diagnosis, even though there's something going on genetically. So just because you don't see something doesn't necessarily mean that it's nothing, especially for Ashkenazis. That's why I'm a very big, strong proponent of testing everybody who's Ashkenazi, even if they don't have this kind of history. Because it really could happen to anybody. I, of course, understand that this testing is not for everybody. Not everybody wants this information at certain points in their lives. Maybe they'll want it, but maybe they don't want it at a younger age. Maybe when they're in the dating scene, they might not want this information. There's many reasons that are totally reasonable and very understandable, but I also think that having the information could be really helpful for themselves and also for their family members at some point. So how JScreen works. I thought I had another slide. So the way that it works is people go to the website and they register for either the reproductive carrier screening test or the hereditary cancer test, or both. Many people do both. We send them, they register for the test. It's $49 to be part of the JScreen program. And then we have a third-party physician who does the ordering for the patient. So you, as the referring provider, you don't need to do anything. You just need to tell them that they should go to JScreen, and then we take care of the rest. So we'll order the test for them. We'll send them the spit kit in the mail. They spit into the tube, send it back to the lab, and then the results come back to us and to the patient. And then we discuss them with the patient, either again by phone or by Zoom. We always recommend that our patients share the results with their doctors. We offer to speak to the doctors also if they want. We do recognize that not every doctor is a genetic specialist, so we know that this is not necessarily your bread and butter. We're happy to help you understand what these results mean and to bridge the gap and to let you know what guidelines might be available in terms of your practice or maybe where to refer out. We want to help you understand the results so that your patients are taken care of. So that's what we're here for as the genetic counselors. Like I think I mentioned earlier, the genetic testing is billed into insurance. For people who are not using insurance, it's $249 for either test. JScreen in your practice, I know that everyone here is in training, but just good to know for the future. We send brochures all over the country to different doctors' offices. So if you are ever in an environment where you think that it would be helpful for your patients to have a JScreen brochure where you can just send them to the website, we can send them to you and you could give it straight to the patient. We work with a lot of practices. We can handle the counseling for them. We can send the providers the results if they want them. We can track the patients to see how many people came from that office. We can always give a discount on that $49 program fee. So we're here to support you in any way that you need the support. We just want you to know that we exist and we're happy to kind of take the responsibility of seeing your patients and the genetics part of your patient, not the other stuff. And that is the end. If anybody has any questions, they can reach out to me. If anybody here would like to get tested themselves, just to kind of like test the waters and see what it's like, we're happy to have you be a patient of ours. You can just email me and I can give you a coupon code to kind of get you through. Just let me know your name and what city you're from, because very often we have grants from different cities that we can, use for testing. But if you're interested in learning about yourself and also seeing what the process is like, please, come through. We see many, many, many thousands of patients a year, and we would love for you and for your patients to become our patients. And that is the end of my presentation. If anyone has any questions, I'm happy to answer them. And if anyone has any questions in the future, you have my email. It's estie@jscreen.org.
Definitely happy to put anyone in touch with Estie if anyone is interested. If there's any questions?
I have a quick question.
Oh,
First of all,
awesome.
thank you so much. That was very interesting. For the most part, do you guys take most insurances across
Yeah.
the board, or okay?
Yeah.
Okay, that's good. And
Yeah,
then
and
like
if a patient for whatever
Medicaid.
reason, and Medicaid,
Okay.
Medicare, yeah. If a patient doesn't meet criteria or for whatever reason they're not covered, like I said, they could do the self-pay, which is $249. And if there are financial barriers, like we'll help them. Like we want people to get tested and we will make sure that cost is not a barrier for anybody.
Good to know. Thank you.
A physician or a student wants to organize something with JScreen, they could also reach out to you, right? Just I want to
Yeah, yeah. So we do screening events also. We go to different
Mhm.
campuses all around the country. We've been everywhere, like all types of locations. We've been at conferences, we've been at schools, we've been at JCCs, we've been at shuls, like anywhere that you think. We've been into like a million Chabads and Hillels, like anywhere that there are Jews, we are there, and we're happy and willing to travel.
Amazing. And
I have
no more last
another
question.
question.
Oh,
Sorry.
perfect.
Yeah.
Okay.
I'm just curious, have you seen a pattern in I guess, the communities of people that are interested in hearing the results versus not? Like, do you have a lot of patients like, we don't actually want to know what the results are, similar to like the Derry Sherm style, where they're like, we don't want to know, just let us know if there's something going on? Has there been like a trend?
Yes, very much so. I think it really depends on the location. I think in the more like modern Orthodox world and more to the left of that, people are very okay hearing the results. They want to hear the results. They want to speak with us. In the more Haredi, Yeshivish, Hasidish world, I think that Dore Sharim is the model that they're more interested in. It gets a little bit murky when we have couples that are like mixed, so one person might have done Dore Sharim, the other one didn't. It gets a little bit complicated because Dore Sharim doesn't give the results, so we can't compare them. So that's always a fun situation, which happens pretty often. But yeah, I would say there are pretty clear lines um, depending on the community.
Got it. Have you guys had cases where Darusharm will work with you guys and be like, okay, you have, okay, not at all. Interesting. Okay.
No.
I mean, makes sense, but it's, yeah, that's interesting. Okay. Thank you so much. I appreciate it.
Yeah, it's yeah. I think that Dory Sharam is incredible. Like they really put Tay-Sachs on the map. They put genetic testing on the map, and our community would be in a very bad place without them. And I really respect them for that. And I think it's really creative and really smart what they did. Like they did it so great for that community. At the same time, they're not keeping up with the times as much, and it's really sad when we see cases where things could have been prevented and they weren't. Listen, we can't prevent everything, like we're not God, but there is more that we can do. And that's why, like, clinically speaking, I do recommend doing the testing through like a clinical lab that does more comprehensive testing.
Thank you so much.
Thank you everybody for coming. Thank you again, Estie, for your presentation, which was amazing. And again, if anyone wants to get in touch with Estie, feel free to reach out to me on the JPN chat. And have a great night. Thank you for joining us.
Thank you.